Welcome to The Explainer. Today, we're diving into a seriously high stakes, absolutely fascinating intersection where the rigid rules of the courtroom crash right into the dynamic, messy reality of the hospital ward. We're talking about clinical medical ethics. Specifically, we're looking at that incredibly delicate balance between a patient's right to choose and a doctor's duty to heal. This isn't just abstract philosophy, these are the actual frameworks used every single day to make literal life or death decisions. So let me start by throwing a pretty provocative question your way. Can a legally incompetent patient make their own medical decisions? Your immediate instinct might be to just say, well, no, of course not. But the truth is actually a lot more complex than that. And understanding why gets to the very heart of who holds the ultimate authority over a patient's body. Let's look at how we're going to break this all down. Here is our roadmap for this explainer. 1. Competence versus clinical capacity. 2. The 4 pillars of capacity. 3. The right to refuse. 4. Emergency implied consent. And 5. The surrogate hierarchy. Okay, let's jump straight into section 1, competence versus clinical capacity. This is probably the most critical distinction in medical ethics, and honestly, it's where a lot of people, even seasoned professionals, can get tripped up. Legal competence, that is global, it's static, and it's decided entirely by a judge in a court of law. It essentially dictates whether a person can be held accountable for their actions overall. But clinical capacity, totally different ballgame. That's a medical determination. It's dynamic, it's task-specific, and it's assessed by a physician right there at the bedside. It can fluctuate wildly based on a patient's underlying metabolic state, medication effects, or just an acute illness. It relates entirely to the specific medical intervention being proposed at that exact moment in time. Because it's so dynamic and task-specific, clinical capacity really isn't an all-or-nothing game. Think about it. A patient who has been deemed legally incompetent by a judge, or maybe someone dealing with mild dementia or a psychiatric illness, might actually retain the clinical capacity to make basic medical decisions on a good day. Actually, flip that around. A perfectly legally competent person could temporarily lose their clinical capacity during an episode of acute delirium. For instance, the cognitive capacity you need to consent to a simple blood draw is vastly different from what you need to consent to a complex multi-organ transplant. If the doctor determines the patient grasps that simple choice, their autonomy is respected for that specific task. Moving on to section 2, the 4 pillars of capacity. So how exactly does a doctor figure this out in real time? How do they objectively evaluate and prove a patient has this dynamic capacity? Well, they use a very specific framework. It's basically a strict clinical checklist. For informed consent to be legally and ethically valid, the clinician absolutely has to document that the patient satisfies every single one of these 4 pillars. First, the patient has to communicate a clear, consistent choice regarding their care. If their decision is inexplicably shifting from minute to minute, that's a huge red flag indicating a lack of stability. Second, they have to demonstrate a basic understanding of their medical diagnosis, the proposed intervention, and the alternative options. Third, they must appreciate the clinical consequences, meaning they truly grasp how this choice directly impacts their own health and life expectancy. And fourth, they have to engage in a rational manipulation of information, basically providing a logical, step-by-step reasoning process to justify their final choice. Which brings us to section 3, the right to refuse. Now, what happens when a patient checks all 4 of those boxes, fully understands the situation, and then looks their doctor right in the eye and says no to a life-saving treatment? Consider this dramatic real-world case study. We have a 52-year-old woman with ALS, which is a degenerative disease. She's been on mechanical ventilation, and attempts to wean her off have completely failed. She's looking at spending years in a ventilator facility. Now, her parents desperately want her to go, but she refuses. She clearly states she would rather have life-sustaining treatments withheld right now than live in that facility. Even though her decision will literally lead to her passing, she expresses a consistent choice, understands the risks, appreciates the significance, and reasons logically based on her values, prioritizing comfort over prolonged life. Because she successfully satisfies all 4 of those capacity components and her choice isn't driven by something like acute psychosis, she has the absolute right to refuse this intervention. Her autonomy is paramount. Now, while patient autonomy is the absolute cornerstone of medical ethics, it does have strict limits. A doctor can overrule a patient's refusal in a few very specific scenarios. Obviously, if they lack the decision-making capacity we just discussed, the physician has to step in. Secondly, minors generally require parental consent, though there are a few exceptions for things like life-threatening emergencies or specific reproductive and substance abuse treatments. And finally, your autonomy ends right where public danger begins. So if a patient has a highly contagious, dangerous disease like active tuberculosis and refuses isolation or treatment, the physician and public health authorities can mandate it just to protect the public. Okay, Section 4, Emergency Implied Consent. This brings us to a really critical pivot point. What happens when the whole system breaks down? What if an unconscious patient is rushed into the ER after a severe car crash with massive trauma? There's no family around, absolutely no time to search for an advance directive, and the patient obviously can't communicate. Well, in these acute, life-threatening emergencies, doctors do not wait around for legal permission. The ethical baseline is to save the life immediately. This is driven by the principle of implied consent. The law just assumes that any reasonable person would consent to life-saving treatment in an emergency, which gives doctors the green light to execute immediate life-sustaining treatment and prevent serious harm or death. And finally, Section 5, the surrogate hierarchy. But emergencies pass. Or we run into non-emergent situations where a patient has permanently or temporarily lost capacity, say a patient with severe advanced Alzheimer's disease. If they haven't formalized their wishes in a living will or a durable power of attorney for healthcare, who actually decides? Well, the law mandates a strict legal protocol for finding a proxy, and there's this incredibly sticky mnemonic to remember the descending order: spouse chips. I know, it sounds like a terrible snack, but it is a fantastic legal framework. First, the medical team looks to the spouse. If there's no spouse, they move down to the adult children. Next are the parents, then the siblings, and finally, close friends. The medical team has to follow this hierarchy exactly to find the legally authorized surrogate decision maker. But here's the absolute most important part. Exactly how does that surrogate make the decision? It's governed by this ethical concept called substituted judgment. A surrogate is not simply picking what they personally think is best. And they aren't just blindly agreeing with what the doctor thinks is the best objective medical option either. Their ethical obligation is to step right into the shoes of the patient. They have to make the exact choice the patient would have made for themselves based entirely on the patient's known values, beliefs, and previously stated wishes. Which leaves us with this final, honestly pretty heavy question. If your capacity disappeared tomorrow, does your surrogate know exactly what you would want? It is a stark realization that the line between medical intervention and personal autonomy so often rests in the conversations we have right now while we're perfectly healthy. I really hope this explainer has clarified the fascinating ethical framework physicians use to navigate these difficult waters, and maybe, just maybe, it'll spark a conversation you need to have today. Thanks for joining me on this deep dive, and I'll catch you in the next one.